So we're again trying to build more and more demonstrations to display the concept of relational motion. So one thing stays still and one thing moves in relation to it. So if we're looking at the shoulder, now this isn't how I would often work on the shoulder. In lateral recumbent, I would usually work from behind the patient because I'm better able to stabilize them with my abdomen, keep them under control. So we're looking at our first and second concepts within patient positioning, which is the table makes stable, and the less stable means I need to make the patient more stable. So we're looking at those concepts, as well as the third concept, which would be the space between us is unstable, so the concept of negative space. But just to understand this, if I'm looking at the glenohumeral joint, in a very, very generalized sense, I'm looking right in around here. I can stabilize the patient's body, and I can move the humerus in relation to the glenoid. Okay, so I can move the humerus in relation to the glenoid, or the glenoid fossa, which is on the scapula. Now, in a related sense, what I can do is I can keep the arm still, okay, and I'm palpating around the humerus. I have some contact essentially on the external surfaces of the humerus through multiple layers of tissue. I have some contact with the glenoid or a related portion of the glenoid in the scapula. Now what I can have the patient do is I just want you to roll your body backwards this way. Keep going, and let go, come back, okay? Roll your body towards me. So in a related sense, and let go, good. So in a relatable sense, I can get an anterior and posterior glide when the patient moves their body in relation to the humerus. So essentially I can get the body to move around the humerus. Sometimes, depending on the tenderness for the patient or the general situation, that may be a more useful approach. So I can stabilize the humerus and move the body underneath the humerus, or move the body around the humerus. I generally don't get as large a range of motion by doing that because the body doesn't have the capacity, or the thorax at least doesn't have the capacity to move as far as the humerus in relation to the glenoid, but I can get some motion, so I can put the patient into either a position of bind or a position of ease, get them to move their body underneath so that the muscles that would control the actual humerus, the deltoid, the pectorals, or the pectoralis major, the muscles of the rotator cuff, so that they don't have to activate, but what I can do is I can still get those gliding motions.